I think we're being filmed, or we are being filmed. So they decided to do it in here. And actually this, I think, is an extremely important talk, and hopefully I'll give you some good information and you'll think the same thing when we're finished. So my name is Juan Frias, and I'm an endocrinologist, and I practice in Los Angeles, and I have 3 clinics in Los Angeles, and we do a ton of clinical research there as well. So we investigate most of the drugs that are out today for type 1 diabetes, type 2 diabetes, obesity, something called fatty liver disease as well, blood pressure, so on and so forth. And we've been in Los Angeles for about 30 years. I've been there for about 7 years or so. And I did, though, my endocrinology training, what's called your fellowship, so my subspecialty in endocrinology here at UCSD, about 20 years ago. And when I was a fellow here, Dr. Edelman was the fellowship director. So he was a strapping young, there he is, howling in the back, strapping young assistant professor in those days. Yes, round of applause for Steve Edelman. So, and as you can imagine, never a dull moment during those 3 or so years of fellowship, and we've remained very close friends and colleagues since then, and it's always been my privilege to be very involved with this organization, which now, as you know, is celebrating 25 years of this conference, which I think is phenomenal. I just spoke to the healthcare providers that were here, so in association with the patient conference, there's also something called Making the Connection, which is a certified medical education program for healthcare providers with an interest in diabetes. And it really is an ever-changing field. It seems like over the past 10 years, the number of new diabetes drugs, both oral medications, injectable medications, is just growing and growing. And the other thing that's been growing a lot due to very excellent clinical research is the importance of really realizing the importance, particularly in diabetes and in pre-diabetes as well, of reducing the risk of cardiovascular disease. So we clearly, as we treat patients with diabetes, need to be paying very close attention to the glucose values and the A1C, and we'll go over that in a bit. But also, and I would say just as importantly, we need to be paying attention to the so-called modifiable risk factors for heart disease. So this is the blood pressure, the cholesterol, whether or not you should be taking an aspirin or what we call an antiplatelet agent, not smoking, trying to maintain the best possible body weight, really reducing the risk of heart disease. And this is sort of the title of the lecture is, Do You Know Your ABCs? And this is clearly a Dr. Edelman slide, but we're not talking about kindergarten. So this is very important, and we'll go through. I think it's a nice way to remember sort of these very key factors in the management of diabetes. And controlling these ABCs, and actually we have ABCD here, and I added an E to this lecture, and you'll see that in a sec, will absolutely reduce the risk of heart disease, not only of getting heart disease if you don't have it, but of preventing the advancement of heart disease in patients who have heart disease. And unfortunately, heart disease is much more common in patients with diabetes than in persons without diabetes. And these are some statistics, and this is certainly not to scare anyone, but this is why it is so important. And if we see here, and this is data from the US, the persons with diabetes are 2 to 3-fold more likely to have heart disease than people without, so the risk is higher. About 30% of coronary stents that were implanted were in patients with diabetes. You see there almost 300,000 heart attacks annually. And the risk of heart disease in general is about 2 to 4-fold greater in persons with diabetes. And unfortunately, the risk of dying, probably the leading cause of death in persons with diabetes, and it's a very common cause of death in people without diabetes as well, but is cardiovascular disease, so either stroke, a heart attack, Peripheral vascular disease or issues with the large vessels in the legs, very important in type 2 diabetes as well. So I don't want to ever minimize what are so-called the microvascular complications, which are the eye, retinopathy, the kidney, nephropathy, the nerve damage that's possible, neuropathy, and those are generally caused by high glucose. And in sort of in medical terms, we call those diabetes-specific or glucose-specific complications. But both are very, very important, preventing the microvascular or the small vessel disease like eye disease and preventing the large vessel disease, which we call the macrovascular disease, which is atherosclerotic cardiovascular disease. So stroke, heart attack, and peripheral vascular disease of the large vessels of the leg. And again, knowing your ABCs and making sure that you have the discussion with your doctor about how to best address these, extremely important. And this is what they stand for. A could be aspirin. You know, should you or should you not be on an aspirin? It's not for everyone, but certainly it is for a lot of patients. A, also A1C, and we'll talk a bit more about that as well. B for blood pressure. C for cholesterol, D for diabetes drugs. And this is very new because previously, you know, we had drugs to treat diabetes and lower the blood sugar, and they did that, and many of them in a very, very good fashion. But now we have drugs that not only lower the blood sugar, but also have what we call extraglycemic or effects beyond just glucose lowering. And those might be reduction in blood pressure, reduction in body weight, and reduction in the risk of cardiovascular disease. And these are so-called, and you've probably seen this a million times on TV when you see commercials about Jardiance, empagliflozin. But some of the what are so-called SGLT2 inhibitors, and also some of the GLP-1 receptor agonists like liraglutide, which is Victoza, or semaglutide, which is Ozempic. And if you watch TV, you certainly know the Ozempic song, and I'm not going to sing it. E, I added to this talk, is eliminate smoking. And for my patients, and I think just in general, this is one of the most difficult things to do. It is very, as you know, if any of you have smoked before, very, very difficult to stop smoking. So this is something that if I have patients who are smokers, and they can't stop, they do go to smoking cessation classes. So A, aspirin and A1C, B, blood pressure, C, cholesterol, D, diabetes drugs, E, eliminate smoking. And let's start with aspirin. In general, if you are going to take an aspirin, usually it would be a baby aspirin. It's very effective, particularly in what we call secondary prevention in patients who already have had a heart attack, who already have had a stroke. And it's not every type of stroke. It's not a stroke from bleeding. There, an aspirin may be contraindicated. But a stroke or other heart disease. This has to be discussed with your doctor clearly. It's very, very inexpensive. And what it does at the end of the day is sort of thins the blood, if you will, and prevents clots or reduces the risk of clots from forming, which are the clots that oftentimes can block blood vessels and lead to a heart attack or to a stroke. So who should take an aspirin? Basically, if a person has diabetes and has heart disease, already has had a heart attack, or already has had an issue, cardiovascular disease, and is not allergic to aspirin, in general, these are patients that should all be on an aspirin. Also, the recommendation is that patients who are over 50 and have a lot of risk factors for heart disease, even if you've not yet had a heart attack or had a stroke, many times your doctor may place you on a baby aspirin as well. In general, people that are less than 40 years old that haven't already had a heart attack or that are not at very high risk, you know, it's probably not worth it. And also, I'm always very careful with elderly patients. And elderly is sort of, you know, it depends. It used to be elderly was like over 60 or 65. As I'm sort of nearing that age, it becomes sort of a lot younger. But certainly patients who are 70, 75, 80, it's a discussion to have with your doctor for anyone, but especially patients who may be at increased risk of bleeding. I mean, the complication of aspirin therapy is that it can cause a gastrointestinal or a GI bleed, particularly in patients who've had one before or who have had ulcers, for example. So this is a discussion to have, but certainly if you've already had a cardiovascular event, if you're over 50 and have very high risk, meaning high blood pressure, high cholesterol, maybe a family history, this should definitely be a consideration. And then for patients who are allergic to aspirin, there are other medications that can be considered, in particular one whose brand name anyway is Plavix. All right, so what's the other A? We had aspirin, what's the other A? A1C, absolutely. So A is for A1C, and I'm probably telling you something you already know, but it's always worth repeating. Everyone should know, everyone with diabetes, and probably people without diabetes as well, because you do know that about 1/4 of patients with diabetes in the United States are undiagnosed. So if you do not have diabetes, you should know what your sugar is, your fasting glucose, and probably should know what your A1C is, because if you have prediabetes, it can be prevented, or type 2 diabetes can be prevented, and there's action that can be taken. But anyone with diabetes should know not only what their A1C is, but also what their A1C target is. So what are you trying to reach with respect to A1C with your diabetes therapy? So the A1C is basically an integrated measure of your blood glucose over the past 2 to 3 months. Okay, so it's not just the morning glucose. It takes into consideration all of your glucoses over the last 2 to 3 months. And a normal A1C is less than 5.7%. But in general, in patients with diabetes, we're trying to reach an A1C of less than 7%. What's been shown in a number of long-term clinical trials is that with an A1C of less than 7%, there is less risk, or almost very little risk, of development or progression of those microvascular complications, eye, kidney, nerve damage. So there's a definite correlation between lower A1C, so lower average sugar, and less risk of developing complications and less risk of those complications, if you happen to have them already, progressing or getting worse. So this just shows there's some nice sort of correlations between the average glucose throughout the day. So if you check your sugar a reasonable amount, 2 to 4 times a day, and you look at your 14-day average on your meter, for example, an average sugar of about 170, so somewhere between 150 and 170, correlates or is sort of equal to an A1C of 7%. And then each percentage point of A1C is about 30 milligrams or 30 points of glucose. So you can see here 7% is about a 170. If you check your sugar a reasonable amount before and after meals and you get a 14 or 30-day average of about 200, that's going to be an A1C of about 8%. And we'll add another 30, so 240 would be 9%. So in general, I tell my patients, we're not getting A1Cs all the time. We get it, if the A1C is not a target and I change a patient's therapy, I recheck the A1C generally in 3 months, certainly no more than 6 months. Make sure that it's coming down, and if it's not, we make a change in the therapy. But you can generally, let's just say, for example, I have a patient, A1C is 8.5. I make some changes in the therapy. The new A1C, or the A1C that really reflects what that new medication is doing, is going to be in about 2 months. But in the meantime, we're sort of striving towards an average sugar throughout the day of about 150 to 170, so somewhere around 7%. So I would say that you should talk to your healthcare provider about what your A1C goal is. I have patients whose my target is 7.5 or maybe 8%. Generally, these are very elderly patients that, hey, I don't need to get them down to 6.5. And I have very young patients, for example, that I may want sort of what we call tighter control, and I may want to get it down lower. The bottom line is, in my practice, and I think most people would say, and most of the guidelines tell us, try to get to the best possible A1C with the least possible side effects. So I do not want a really low A1C and the patient's having a ton of hypos or lows. That's no good. That's not good glucose control because the lows are very dangerous. So I'd rather increase the A1C a bit and eliminate those lows. But everyone should know, again, what is the target A1C, and ask your doctor when you go in, hey, what's my A1C? I have a lot of patients that come in that have had diabetes for 10, 15 years. They have no idea what an A1C is. They don't know if it's been checked. I'm sure it has been checked, but they just don't know. But you should know your target, and if you're above your target when you see your doctor, you need to say, what are we going to do about this? I'm above my target, and have that discussion. And if your doctor doesn't know what an A1C is, you probably should switch doctors. So that would be my advice. All right, so A is for aspirin and A1C. Do we have a question? The question is, how low is too low? You know, there's no too low. You don't need to be like normal. I do have some patients on so the question was, how low is too low in A1C? As long as you're not having hypoglycemia or any side effects from getting too much medication, there really isn't a too low. But it really doesn't need to be lower, I would say, than 6.5. You know, there is very little risk of having complications when it starts getting less than 7. Probably the biggest benefit you get is when you go from around, 10 to 8. That is a big reduction. And oftentimes, with some of my patients, for a number of reasons, maybe 8's as good as it gets. But if they were 12 before and they got to 8, they've reduced their risk by several fold. They'll still get some benefit from coming to 7, but not as much as going from like 9 to 8. But there is no too low. And with some of the medications we have today, like semaglutide or Ozempic combined with an SGLT2 inhibitor, I mean, I have patients now who have A1Cs of 5.6, 5.7 with weight loss and without hypoglycemia. As long as they're not having those side effects, that's fine. But they don't need to be that low. That's a great question. So back to our outline here. So A, aspirin, A1C, again, talk to your doctor. Blood pressure. Blood pressure is very important. One of the things that I just gets on me is when I do get these patients with A1Cs that are very, very low, and we're very happy about the A1C, but the blood pressure is completely out of whack. The blood pressure is critical to reduce the risk not only of heart disease, but also of those microvascular complications. So the eye disease, the kidney disease is very much affected by blood pressure as well. And blood pressure can be tricky. I mean, as you know, with diabetes, today and I'm talking about type 2 diabetes, type 1 diabetes treated with insulin. Type 2, we just have so many different medications now. And what we do as physicians and healthcare providers is we try to combine them, because many of them have complementary mechanisms by which they lower the glucose. And it's the same thing with blood pressure. Most patients with hypertension or high blood pressure will need more than one blood pressure medication. And in fact, the recommendations, if you look at the American Diabetes Association recommendations for the treatment of blood pressure, it says that if a patient has a blood pressure over 160/90, so the systolic blood pressure is the top, if it's over 160 and the diastolic or the bottom is over 100, that we should initiate combination therapy, so therapy for blood pressure with 2 medications from the start. I don't always do that. Oftentimes I'll start with one, but I very quickly will add a second blood pressure agent as well. So it's sort of the same philosophy as with glucose. We're combining medications that have complementary actions to lower the blood pressure. And just like an A1C, we should know what our target blood pressure is. I think I'm saying everything that's on the next several slides, but here it is. So know your numbers, okay? So blood pressure should be measured at every doctor's visit. And in fact, the recommendations, and I do this with my patients also, is buy a blood pressure cuff, because oftentimes it's very different at the doctor's office. The so-called white coat syndrome is real. Patients will have higher blood pressure in the doctor's office, particularly if they get a little nervous around the doctor or the nurses, it's higher, and then they go home and it's fine. So I have my patients either purchase a blood pressure cuff or go into the pharmacy, maybe the week before coming in, check their blood pressure in one of those machines and jot it down. And I always tell my patients also to bring their blood pressure cuff, unless there's usually very small, to the office and we can check it against our cuff, which is calibrated by technicians that come in and calibrate it. And again, I think writing it down is important because if I tell someone to just do this and they come back and say, doctor, it was fine, I'd like to see it written down if possible or they forget. But in general, what we would like to see is a systolic blood pressure, the top number less than 140, and the diastolic, or the bottom number, less than 100, or 100, definitely less than 100, less than 90. So 140 over 90, we'd like to see it lower than that. There are some circumstances where we would want to see less than 130 over 80, particularly in patients who have very high risk of cardiovascular disease. That said, we need to be very careful with the side effects of these medications. So you don't want someone, or I don't want to have a patient who's getting dizzy every time they stand up because the blood pressure gets too low, because low blood pressure can be dangerous too. So sort of a fine balance, but in general, something in the 120s or 130s over 70s or 80s, perfect. Again, less than 140 over 90 for most people with diabetes. Some people need a lower blood pressure, and I think it's very important to know what your target is. And the other thing, and I didn't mention it, is very important, is that, again, don't feel bad, if you will, if you need 2 or even 3 medications. Most of my patients take 3 medications. They're on an ACE inhibitor, something like lisinopril, or an ARB like losartan or Cozar. They're on usually a calcium channel blocker like amlodipine and maybe hydrochlorothiazide or a diuretic. I prefer to combine 2 or 3 medications at lower doses than give one big dose of one medication. But anyway, your doctor can talk to you about that, but you don't want to run around for a long period of time with blood pressures like in the 180s over low 100s or 90s. Over time, it's just too much pressure in those blood vessels, and it does damage to the blood vessels, and that is what can lead to a clot and a heart attack or a stroke. And I have a question here. Feel free to ask questions as we go. We have plenty of time. The question is there an advantage to taking a blood pressure medication like losartan even if your blood pressure is normal? And the answer to that is as long as you're not going too low, and they could have some, or does, that has advantages to the kidney. So in patients who have diabetic kidney disease, and again, your doctor will need to let you know this, and have particularly patients who have protein in the urine, some of these blood pressure medications actually have a positive effect on the kidney. So when we choose the blood pressure medication for a patient with diabetes, we'll usually choose what's called an ACE inhibitor or an ARB, like the one you just mentioned, because those medications not only have blood pressure lowering effect, but also have positive effects with respect to kidney function and reduce the progression of kidney disease in patients with diabetes. So there are some circumstances where a patient would be on one of these blood pressure medications, not necessarily for the blood pressure, but to help with the kidney disease. And I see a question back there. Mm-hmm. No, you know what, and I don't know, we can talk about that after because that's called orthostatic hypotension. Sometimes, depending if you're on medication, sometimes when someone stands, the blood pressure drops a bit. You have to be standing for several minutes for it to sort of equilibrate. Probably the most accurate way to check it, and that's okay to do that, is sitting. Feet on the floor, sitting, not resting back, kind of just sitting calmly with this part sort of at heart level. So there are ways to check it. If you stand like that, as long as you're not feeling dizzy or anything, you're probably fine, but they should wait a little while to sort of let it re-equilibrate. Yeah, no, they should probably wait a little bit. I think the sitting is probably better, but we should talk because I'd want to know whether you're on blood pressure medication or not. But yeah. So yeah, let's talk after about that. But generally, it should be done sitting. There's certainly circumstances where you want to know, lying down, sitting, and standing as well. But you should stand for a good 5 minutes before they recheck it. So if you have, another question here, and then we're going to move on for blood pressure. It probably matters. We're not talking like 10 millimeters of mercury or anything, but I think every little thing does make a difference. And also I tell my patients, don't have a cup of coffee right before. If they've just run in and they're kind of late for their appointment and they're all frazzled, I don't want to check their blood pressure. So it's got to be sort of relaxed too. And the other thing I would say, if someone comes to the office and they have mild hypertension, 150s over something in the 90s, I don't immediately start medication. I will say, let's check it over the next month, get a cuff or check it at the pharmacy, come back in. So usually I need sort of a confirmatory reading because it can fluctuate quite a bit, much more certainly than glucose is or A1C, which is a much more stable value. But diet is very important for high blood pressure, low salt diet in particular. And again, this talks exactly to these medications, the ACE inhibitors and what are called angiotensin receptor blockers, or the ARBs. Very, very common in patients with diabetes, and they also protect the kidney, and they also protect the heart, quite frankly. So very, very important. Weight loss can actually play a very big role also in lowering blood pressure, and not drinking too much alcohol as well. And this is clearly not, this is a Dr. Edelman picture clearly, this is not a way to protect the heart. So I don't know why he has that in there, but pepperoni pizza is not low salt, and that is certainly not low calorie, so that is not recommended therapy. I'll have to ask Steve what the joke is with that, but that's not what you should be doing. So aspirin, A1C, blood pressure, now cholesterol, and this is critical, and there have been some very nice advances with respect to cholesterol lowering medications. But if you think about cholesterol, there's the total cholesterol, and then there are different cholesterols. The total cholesterol, when you get the value, is made up of what's called your LDL cholesterol, which is sort of your bad or lousy cholesterol. You want that to be low. Your HDL cholesterol, which is in technical terms your high density lipoprotein cholesterol, that's the healthy cholesterol. That one you want high. And then triglycerides, or fats in the bloodstream, and these are called your very low density VLDL cholesterol. So these all make up your cholesterol. So you really need to know, when you see your cholesterol values, you need to know, what was my LDL, what was my HDL? Because sometimes the total cholesterol may be high, or a little bit high-ish, certainly over 200, because you have a very high HDL cholesterol. That's good. That actually protects. But what you don't want is a very high cholesterol because your triglycerides are really high and your lousy or LDL cholesterol is high. So when we look at targets, particularly for heart disease, the most important of all of these is the LDL cholesterol. If you have diabetes and you have heart disease, so you've already had a heart attack, stroke, you have peripheral vascular disease, the target LDL cholesterol is less than 70 milligrams per deciliter, so less than 70. The higher the HDL, the better. So here are sort of the targets, and then we'll go to the question. So the goal in general, if you have diabetes, you should have an LDL cholesterol less than 100. If you have diabetes and you already have cardiovascular disease, it's been diagnosed, less than 70. Oftentimes the statins will get someone less than 70 anyway. And this is one situation where the lower the better. And there really is no issue. Now we have these injectables that are injected either once a month or every 2 weeks, called PCSK9 inhibitors. They will get, I have patients who have LDL cholesterols of like 20. And there's some concern that maybe it can almost be too low, that you need LDL cholesterol for certain functions. But you see HDL cholesterol, you want it high, so higher than 50. And triglycerides in general, you want less than 150. And the triglycerides move very closely with the glucose. If I have a patient with type 2 or type 1 diabetes who's very poorly controlled, say A1C 10, usually and the glucoses are high, the triglycerides will also be high. As we treat the diabetes, the triglycerides do come down, but oftentimes the LDL cholesterol does not. So that requires therapy, and that probably I would say, well, they're all really important, this and the blood pressure. But this is relatively, I mean, nothing's easy, but relatively easy to treat with a statin medication, so atorvastatin, Lipitor, or rosuvastatin, Crestor. And if needed, then we can add a second agent to the statin. So I had a question over here. No, it's not too low. 40, you're phenomenal. That's awesome. Are you on therapy or not? Crestor, yeah. So Crestor is rosuvastatin. That's a great statin. So the question was, you know, is 40 too low? Nope, 40 is great. If the cholesterol is normal, is there an advantage to taking a statin? Potentially, and it depends what we mean by normal too. So if, for example, if I have a patient who's had heart disease, chances are their LDL cholesterol is not going to be less than 70. But if it was, would I start a statin? I think I probably would. There are probably some actions that are positive from the statins beyond just the LDL lowering. But that's a pretty rare circumstance, you know. But I think I probably would. And you'll find some, certainly if you talk to cardiologists, many of them will, irrespective of the cholesterol level, they want all their patients on a statin based on data, but also sometimes based on their clinical experience. Probably not necessary, particularly if less than 40 years old. You know, so they do, if you look at the American Diabetes Association guidelines on cholesterol, it sort of gets divided into under 40 and over 40 years old, and the risk, the 10-year risk for heart disease. And in someone who's under 40 with a lower than 20% risk over the next 10 years of having cardiovascular disease based on some risk calculators where we input data, the recommendation, unless they have a lot of risk factors, would be not to start a statin. But, you know, again, every patient has to be treated individually, and some patients come with such high family history, and, you know, they're kind of borderline, and those generally, you know, personally I will treat, always with an eye on potential side effects, which are relatively rare but can occur, you know. And some of you probably have, so here's who should take a statin. You know, all patients with a previous heart attack or stroke, so we talked about that. So that's what's called secondary prevention, patients who have already had an event and now we're trying to prevent a second event. If the LDL cholesterol is above goal, again, most patients with diabetes between 40 and 75 years of age, and the usual sort of disclaimer, obviously you should talk to your healthcare provider about this. And not to be too afraid, we see not only for cholesterol lowering drugs, but certainly for diabetes drugs as well. You know, all the commercials that come out on TV by the class action suit lawyers. So, you know, I don't want to discount that. I mean, oftentimes they're based on important side effects that have been found that are extremely, extremely rare, but these are conversations you should have, and I wouldn't be scared off about this because we have to always weigh. I mean, I would love it if my patients could have great cholesterol, great blood pressure, great glucose without any medication. I mean, obviously that would be ideal because there are no side effects, but every medication has some side effect. I mean, I've got thousands of patients on metformin. If I read the metformin package insert, oh my gosh, it's the scariest thing ever. You know, it's got a boxed warning about lactic acidosis, and, you know, it'll tell you a million things. There's just no commercials for this. So we just have to be, you know, as physicians and as patients, we need to be informed and we need to be very careful and always let your doctor know if just something bizarre is happening, because the statins can cause what's called myositis, or inflammation of the muscle, and this is really probably the most limiting side effect where patients just cannot take it. It's relatively rare, but it can be dangerous and does occur. And that brings, you know, so what do we do if someone does have muscle aches? I give them generally try a lower dose. That can be done. Take it every other day instead of every day. Sometimes switching from one statin to another, like from atorvastatin to rosuvastatin or simvastatin to atorvastatin or whatever, switching statins. or given it at a much lower dose with another medication. So some of you may or may not be on Zetia, for example, ezetimibe, or the PCSK9 inhibitors, the injections I mentioned that are extremely expensive but are very, very potent for patients who cannot achieve their target on a statin or cannot tolerate a statin. So I think the important thing is that there are a lot of options. And this one was kind of funny. I've got to take my glasses off to read it. It says, pharmacy, each capsule contains your medication plus a treatment for each of its side effects. So whatever. But yeah, we definitely have to be very careful about side effects. And we have a question in the back. Right. Yeah, very good question. So the gentleman's saying, notice these age ranges and to 75. What do you do at 76? Okay, a couple of things. First of all, these are sort of guideline recommendations that come out based on clinical trials. And unfortunately, most clinical trials do not include very elderly patients. They're like, they'll say, bring patients in that are between 30 and 75 or 35. And so these patients are not, unfortunately, because many of them are patients that would benefit from these medications, would benefit, they're just not in the studies. And the other consideration is that, you need to look at a patient, because I have, and look at chronologic age versus sort of physiologic age. So I have a lot of patients that are 55 that actually have the body of a 100-year-old. They've just had a lot of complications. They're not well. And I have some 80-year-olds that will run laps around me in clinic. They're just really, really healthy and will probably live to 110. So I think, this gets discussed a lot. So there is no hard cutoff. It's just general. If you look at guidelines, it'll say in patients over 75, we need to be more cautious with these medications, and there's some times where these medications may not be recommended. But it's not a hard cutoff, and no one just stops at that. I'm sorry? No, that's not true. That's not true at all. These are just some of the recommendations based on the data. And I think with any medication in general, and these are all generalities, whether we're talking about pediatric patients or we're talking about the very elderly, these are populations that usually are on more medications that may have more what we call comorbidities or other diseases which can affect what they take and have more side effects. So we just need to be more careful. But it's not a hard, fast rule by any means. Okay? All right, so let's move on now to, yes, question here. How much? It depends. You know what? It depends on the medication. For example, if we're talking about atorvastatin, 10 milligrams, 20 milligrams would be moderate dose. 40 and 80 would be high. Rosuvastatin just it's lower, but it's more potent. So it's 20 milligrams and 40 milligrams would be the equivalent. So I think your doctor will know, and it's in the label. But every medication is a bit different. You can't say across the board X milligrams will have the same effect. So some of them are more effective at lower milligrams, but it ends up still being one pill a day. So it's always going to depend on the medication, okay? But the most potent statins are rosuvastatin, which is Crestor, and atorvastatin, which is Lipitor. Yeah, question here. Right. Okay, so very high triglycerides. So the question here is, or the comment is, excellent hemoglobin A1C, less than 7%, very high triglycerides irrespective. And we can talk about this after as well, but there's a study that recently came out, it was published actually earlier this year in the New England Journal, looking specifically at fish oils, and one in particular that's now been, it's marketed, it's been approved by the FDA specifically for reduction of triglycerides. The risk with triglycerides of causing heart disease is much less well substantiated than LDL cholesterol. but there is a higher risk of pancreatitis and some other things in patients with maybe, usually if you read the literature, it's like over 500, but certainly some people are getting into the 1500s, 2000s or so. But that, that would be a situation where I would say, the fish oils, in particular the medication that's now approved, would be indicated, probably in conjunction with a statin. But the statins really don't have a lot of effect on triglycerides. They're mostly LDL lowering, but there are medications that are specific for triglycerides. It used to be the fibrates like gemfibrozil. Now really it is, based on this study that was published and other studies that have been done with the fish oils, it is this other medication. That's a good question. Yes, ma'am? Statins the question is about how quickly they're cleared out of the system. It's once daily, and they have a fairly long half-life where they can be dosed once daily. So they don't accumulate over time. They do initially to get to the concentrations that are necessary, but they are still effective, and this has been studied, particularly, like I mentioned, in patients who are having some side effects. Usually it's muscle aches. To be given, it's better to get it once every other day than no statin at all. But they're not going to accumulate and cause any toxicities necessarily. That will be extremely rare. So let's move now to diabetes drugs. And I mentioned this at the onset that previously when I was training, and it wasn't that long ago, to become an endocrinologist, we really didn't have many medications. We had insulin, and we had the sulfonylurea, so your glipizide, glyburide, glimepiride. We didn't even have metformin until 1995. So sort of cutting-edge therapy was adding MPH insulin or Ultralente to glyburide or something. And now we have, I think it's 10 classes of pills that are approved. Within each class, there are oftentimes 4 or 5 medications, and then we have all of these combinations, these fixed-dose combinations that contain 2 different classes, and now we have one combination that contains 3 classes of drugs. So, it's gotten more complex, but I think importantly, we've seen that some of these drugs, and in particular the GLP-1 receptor agonists, that some of you may be on, these are injectables like Trulicity, Ozempic, Victoza, Bydureon, Byetta, and SGLT2 inhibitors, so Jardiance and Vicana, Farxiga, there's one called Steglatro now. So some of these have been shown actually in patients who are at very high risk of heart disease to reduce the risk of heart disease, and the SGLT2 inhibitors like Jardiance and Invokana have been shown to reduce the progression of kidney disease as well and be very useful for patients with heart failure. So I think this is very, very positive that we now have medications that not only can lower glucose, but can lower the risk of heart disease, kidney disease, heart failure as well. And this is something that should also be discussed with your physician or your healthcare provider. In fact, if you look at the new guidelines that the American Diabetes Association puts out for us clinicians, specifically about choosing medications for patients with diabetes, what it says is lifestyle, so diet, exercise, education, and metformin, if there's no contraindication, from the get-go. So unless you have an issue with metformin, like you can't tolerate it because of gastrointestinal issues, or your kidney function is too low to be able to take metformin, everyone should be on metformin. And then, if you've already had a heart attack or a stroke or have heart failure or have significant kidney disease, it should be a GLP-1 receptor agonist or an SGLT2 inhibitor. In all of these guidelines, there's something in there about patients who can't afford or have issues with access to these medications, which unfortunately my clinic is in a very low-income area of Los Angeles, so most of my patients have no insurance. They don't have access to these medications, so we kind of plug along with generic medications oftentimes, but when they do have access, we do need to go with these medications that can be helpful for heart disease if they have already had a heart attack or stroke or had an issue. Eliminate smoking, critically important as well. I mean, this is bad for so many reasons, but one of the key reasons is that it increases the risk of heart disease and of stroke, and of peripheral vascular disease as well. And this is a joke about the real reason dinosaurs became extinct. And I often tell my patients too, I mean, we're spending a tremendous amount of money on cigarettes. They're so expensive right now. If that could go towards their medications or, you know, gym membership or something, it would be critically important. Yes, sir? Does it apply to marijuana? No, it does not, actually. Although that has its issues too, obviously, I mean, in excess in particular. But no, I mean, the carcinogens that are in tobacco and sort of the oxidants, and they're very specific to that. Now, you know, there are probably some other issues with marijuana, but with respect to heart disease, I'm not aware anyway, but that's a great question of, you know, any association between marijuana use and cardiovascular disease, although there probably is something, but, you know. And lifestyle is very, very important. So diet, physical activity, I don't know how to call it exercise. I think it's just moving more, you know, and the diet, I don't even tell my patients go on a diet. I just say, let's eat healthy, you know. And I think most people know what healthy is. That is healthy. That is not, right? This is a good way to exercise. This is not. I had another great one where a guy's walking his dog and holding the leash outside of his car. And this came from Dr. Edelman. This is actually a very famous cross-country skier who was sponsored by Eli Lilly. And the joke is here, if you're going to try cross-country skiing, start with a small country. And I tell my patients this all the time because, you know, don't go too gung-ho. I mean, I'm saying this, feeling it myself. I live in LA, I have a house here in San Diego. My wife is here and I commute back and forth, and she took me to the gym yesterday and we did some crazy class I've never done before, and I can hardly walk right now. So the country I started with was definitely too large here yesterday, but I always tell my patients, you know, do it in moderation, find something you like to do, and just move around, you know, that's the key. And with the diet, just reasonable with respect to portion sizes. And you got to enjoy some good food every now and then, but, you know, not a lot of snacking and that sort of thing. So with that, I will stop. And what I just want to hear, what does A stand for? B. C. D. E. Yeah, excellent. So I'm sure we'll come up with other letters, but I think it's important. And you know what? It's very sort of gratifying to be practicing diabetes today because it's almost an onslaught of different medications and things, but I think we've got some very good medications now that have used appropriately, and some of them are becoming so much easier to use. Once a week injections. Before long, we'll have once weekly basal insulin. Oh, it's so nice to inject once a week and have your insulin requirement. So I think a lot that's coming as well. A lot of research we're doing at the center, and I think it's a good time. And you know, as long as we diagnose early and treat relatively aggressively without getting too nutty, I think patients can do great and you know, live long and healthy lives. So with that, I will stop, and I'll be around here a bit longer if there are any other sort of specific questions for me. So thank you very much.